Hi, everyone. Thank you for having me today. And I've been thinking about how evidence plays into my daily practice. And I just wanted to give a little bit of background about where we're at in terms of the COVID-19 pandemic. We are 21 months into the COVID-19 pandemic, and the number of cases in Australia at the moment sits at 130,000. But that's in contrast to the world, where we're reaching 250 million cases. The number of deaths in Australia is approaching 1,500, while in the world we've seen 5 million deaths. So, as you know, New South Wales was in lockdown for 107 days, and we've just emerged from that. And the current surge peaked in September and is currently on the downward trend. We can see that this pandemic occurred with a perfect storm of events. We saw global warming and unsustainable development, creating perfect conditions for viruses to thrive. Our air travel had increased fourfold since 1990. We now live global interconnected lives, and inequities were rife in society and health systems when we were first encountering SARS-CoV-2. So we can see that COVID-19 thrived due to the large gap between limited, disjointed pandemic preparedness in many countries and a system really unable to cope with a fast-moving and exponentially growing pandemic. I wanted to show this slide because in March last year, I was in Pakistan teaching an emergency life support course. And this was, there were already some rumors of something emerging from Iran. And we had a coronavirus assessment counter right next to the dengue triage counter in the hospital that we were teaching at. And I came back to Australia at the beginning of March, just before the borders closed. Just since this is an evidence conference, I wanted to just recap the definition given by the Cambridge Dictionary of evidence, which is one or more reason for believing something is or is not true. And you would think it's pretty straightforward. So here we are in the middle of a pandemic declared by WHO on 11th March 2020. And I can say that it has really changed the way we practice medicine as well as the way we use evidence to inform our practices. Normally, we use evidence to support all the things that we do for patient care. And I would like to actually say thank you to all of you to help us busy clinicians deal with all the trials that are out there and distilling all the evidence so that we can use it for our practice. And then there's the thing of ordering the evidence according to how the best evidence can be used for our practice. Then once we have that, we have to disseminate the evidence. Once we disseminate the evidence, we could have clinicians improve their patient care based on the evidence. And before the COVID-19 pandemic, this occurred over many months and sometimes over many years. But because of the pandemic, we've had to adapt to how we capture evidence and use it in real time. So in terms of just some considerations for how we share evidence, sometimes it takes too long for us to distill the evidence for us to use in our practice. And what if the delay means more lives are lost? This is the dilemma that clinicians have to face in our day-to-day work. For example, ventilation. I always wondered if we were early adopters of the fact that SARS-CoV-2 were spread via aerosol. Could we have avoided the healthcare workers' infections in Melbourne, where 15% of COVID-19 cases diagnosed there were in healthcare workers. This was before vaccination. And I also considered whether in clinical medicine and public health, whether the evidence that are collected require different methods and also different ways of assessing the quality of the evidence. In the end, I don't think that we really prepared adequately for the Delta surge, but the way we responded is to be lauded. In the first wave, there was an evolving situation of a very easily transmissible virus where there was no treatment, and we were basically just looking at supportive care. There was a lot of anxiety among clinicians, and we assuaged that anxiety by just sharing lots of information through social media. We had a WhatsApp group for senior emergency physicians. In the background, there was this ventilation debate where there was emerging evidence that SARS-CoV-2 was spread by aerosol. But this was mostly ignored by clinicians because they were waiting for more evidence. At the same time, there was concurrent media attention and speculation on everything related to COVID-19 and also proliferation of experts. And this not only created more confusion, and especially among the community, I think there was a desire to have more information, but they didn't really have a source where they trusted. And in terms of clinicians, in the state of New South Wales where I work, we set up various community of practices based in the Ministry of Health, where we had different specialties represented in a clinical council. And through this clinical council, we shared new evidence and adapted our practices in quick time. And when I say quick time, it means in a week or two. So this prepared us well for our second wave, which has been propagated by a very infectious strain, the Delta variant. Unfortunately, when the Delta variant spread in our community, the vaccination rate in our community was below 10%. So we had to really play catch up. And in the end, as I reflected over the last 2 months, vaccination was really a game changer. But while we played catch up with vaccination, we lost a lot of clinicians to staff the vaccination hubs. And this should be a lesson for us to learn for the next pandemic. And we really did not learn from other outbreaks in different countries where the pandemic seemed to be well controlled, and then you would have an outbreak, usually in a community that's poor and marginalized. Witness the migrant community in Singapore, the people living in towers in northern Melbourne, and I could give you many more examples. Let's look at the levels of evidence as assessed by the clinicians. Usually we have expert opinion at the bottom in terms of rating quality of evidence, and of course, Cochrane's systematic reviews right on top. And while I still think that a systematic review is much, much more valuable, during the pandemic, we really had to adjust very rapidly to a changing situation. And sometimes expert opinion is all that we have. So in a way, the pandemic just really changed the way we look at evidence. And it almost is like the triangle sort of got inverted. The common themes that I can see from the COVID-19 pandemic was lots of uncertainty, but also a lot of collaboration from different specialties, which I had not seen to that extent as we saw in the pandemic. It also exposed a lot of health inequities, but we also saw many examples of compassion and celebration of humanity. And I would say evidence just kind of permeated all these 5 themes in different ways. The way clinicians embrace uncertainty was we just look for anything we can grab hold of in terms of randomized controlled trials and also some observational studies. While we usually prefer evidence provided by clinical or randomized controlled trials, in many ways, especially in the first search, we really didn't have that. And so we had experts driving some of the guidelines. But one of the things that I have seen really take off during this pandemic is live guidelines, where we came together as a group, formulated guidelines, but it was changed every few weeks based on more information that we get from different countries or different trials. In terms of also embracing uncertainty, I just wanted to highlight a rule that's not sort of promoted by a clinician, by all of us know General Colin Powell. He was the ex-Secretary of State of the United States, and he was also an amazing general and thought very strategically, and he brought more an army rule to his policy approaches, and he had the 40 to 70 rule. And in this rule, he said that you don't take action if you only have enough information to give you less than 40% certainty of being right. But he cautioned that we shouldn't wait until we have enough facts to be 100% sure, because by then it is almost always too late. So his advice was, once the information is in the 40 to 70 range, go with your gut. Now, I realized that I'm sitting or I'm talking to an audience comprising people who have spent their whole career talking about evidence. And going with your gut seems to really fly against following evidence in your everyday practice. But just stay with me, and I'll point out 2 case studies where I think we really had to act before we were 100% sure. So based on this 40 to 70 rule, I've devised an applicability test to evidence. I just would like everyone to think about whether the evidence we use in real life situation can wait the many months that it takes for us to assess the evidence. Sometimes when we have good evidence, we can run with it. And especially in a fast evolving situation like the pandemic, you have, speed to act versus credibility, and you have eminence versus evidence. How do you resolve these competing demands? And I think the solution is collaboration of experts in real time. That's multidisciplinary, multimodal, multi-agency. So when we apply evidence in real life, we can be more powerful if we work together. And instead of focusing on the quality of evidence, I would implore you to emphasize the application of evidence to a particular clinical scenario. In this case, a very infectious virus. So I was honored to be part of the New South Wales ED community of practice, as well as clinical council, and developing the ASIM clinical management guidelines for COVID-19. And this guideline remains a live guideline that we update every few months. And I was also part of the multidisciplinary expert advisory group on thrombosis, thrombocytopenia syndrome, post-AstraZeneca vaccine. And I could see that during these multiple meetings, we actually could get to consensus, and we could spread these guidelines far and wide via different channels in social media. So I just wanted to show you the two guidelines that THANS and ASIM produce to manage TTS or VIT. And you could see that the approaches are different, while at the same time kind of sticking to a rule of not over-investigating, but setting a limit on our investigations that allowed us to pick out the highest risk patients. And this is also the COVID-19 management for adults with active disease. And I wanted to just juxtapose the two different guidelines from the National COVID-19 Evidence Task Force and our Agency for Clinical Innovation guidelines, which were both produced with collaboration with multiple experts and remain live guidelines. So I just wanted to show this risk matrix for healthcare workers that was produced with feedback from a lot of clinicians that have basically saved our workforce during this Delta surge. It gave a very practical approach to furloughing staff when they've been exposed to patients with COVID-19 and takes into consideration vaccination. Next, we come to epidemic of rumors. I know that people have heard the word infodemics, and there's been a proliferation of web-based experts all weighing in on what we should do in terms of border control, in terms of lockdown, and all of this has been given a lot of press by popular media as well as social media, and it's resulted in some information, misleading information, given a lot more focus than it required. So some of the expert advice really undermine confidence in the AstraZeneca vaccine, and according to this expert, it will cost Australian lives. Time will tell. So I just wanted to jump straight into our first case study, which is on ventilation and aerosol spread of SARS-CoV-2. And one could say that it took many, many months before WHO actually accepted that SARS-CoV-2 was spread via aerosol. And this is important because the way we manage and the way we put infectious patients in different spaces makes a difference when we accept that it's spread via aerosol. So we certainly saw a lot of real life experience showing that people who were not in close contact with each other still got COVID. One can remember the Seattle choir, and we also have many nosocomial infections in hospitals. So food for thought. The second case study I wanted to bring up is vaccine. And while vaccine has been a triumph for collaboration in science, it also has created a lot of different schools of thought and created a lot of misinformation about what vaccine is more effective in which group. And this was certainly amplified by social media to the detriment of increased vaccination coverage before we were hit by the Delta surge. And in terms of communicating evidence, AstraZeneca is an example of really what not to do when you try to communicate about vaccine. And we have thankfully emerged from our Delta surge with not too many deaths, but it's brought our healthcare organization to the brink. So in the interest of time, I wanted to just briefly cover social determinants of health because it's something that the evidence base has not been able to capture and also track outcomes. But as with all aspects of pandemic management, we ignore social determinants of health at our peril. So how do you stay one step ahead? I would, still be practicing evidence-based medicine, but the pandemic has certainly highlighted the limitations of evidence and also the fact that evidence to be useful in real-life situations really need to be rapidly disseminated and very quickly adapted. So again, I'd like to conclude with just the statement that we ignore the social determinants of health at society's peril. Thank you for your attention.